Good morning, everyone. Good evening for good evening for a lot of places. People joining from US, and good afternoon, good evening all around the world. We have viewership, which is so this probably is live everywhere in the world. We are on 64th session of International Weekly Meeting. Okay, sorry. The live started behind me, so I was thinking that who's speaking. So yes, we are live on 64th session. Today we have a very important topic, brain fog, understanding neurocognitive symptoms of COVID-19. I think I was being asked for this topic for very long, and thank you, Monica, for bringing the speaker. We have today with us Dr. Kavita Sharma. She's a medical director of Advocate Arrow at Home Hospices. She's a training program director, Hospices, Hospice and Palliative Medicine Fellowship. Dr. Kavita Sharma graduated from AFMC in Pune, India in 1993, after which she completed an internal medicine residency at Kaiser Permanente Medical Center in San Clara, California. She pursued her geriatric fellowship from John Burns School of Medicine, University in Hawaii. She's currently the medical director and advocate. We mentioned that, yes. Okay, so Dr. Kavita, I would like you to share the presentation, and then once the presentation is over, we will open the round for discussion.
Good morning, everyone. Good afternoon and good evening also. I'm based here in Milwaukee, Wisconsin, and my background is in geriatrics, dealing with patients, elderly patients, and also because of during this pandemic, we were actively involved with a lot of patients who did not unfortunately make it. So doing palliative care for those patients and also caring for them at end of life. So I'm really coming from more of a clinical perspective. I'll try to incorporate some of the pathology and immunological aspects of the neurocognitive involvement. But really, my background is more in clinical medicine. So I'm really going to try and focus on the clinical background of this disease. So no disclosures for me. Our objectives today would be to review some of the pathogenesis of neuro symptoms in COVID, the stages of recovery following COVID, and I'll focus on delirium as well as what the follow-up for long COVID symptoms are for the long haulers of after COVID. Just as a background, hospitalized COVID-19 patients commonly have neurological complications. Myalgias, headaches, encephalopathy, and dizziness are some of the common ones. And these were seen across the world at all places where the pandemic was happening. Anosmia was the most common symptom that was reported. But strokes, movement disorders, ataxias, seizures were also reported, but they were not as common. Neurological complications are definitely very high in patients who are critically ill and those patients who are in the ICU. And while there is no real consensus as to what are the different stages that patients with COVID go through, there is generally agreed upon 3 different stages. So one is the acute COVID, which patients are symptomatic, and this lasts for up to 4 weeks following the onset of illness. When patients have ongoing symptomatic COVID symptoms, usually between 4 to 12 weeks, and then post-COVID are those patients that develop symptoms are persistent for more than 12 weeks. And these symptoms are not really explained by any other underlying diagnosis. And just remember that these stages reflect symptomatic recovery from, fevers and other symptoms that the patients are experiencing, and they're not really related to patients' infectivity or ongoing infection. So it's mostly the symptom-based um, categorization of patients in these three stages. So let's go back to how elderly patients pre-COVID were treated when they presented to the hospital. In general, when patients are hospitalized and they are critically ill, most, at least within the United States, and I believe that several parts across the world have developed special parts of the hospital into an acute care center for elderly. And these centers are really aimed to promote healing and reduce anxiety of patients who are hospitalized. Elderly patients are very high risk for getting delirium. They are at very high risk for having underlying comorbidities that predispose them to longer length of stays and complications during their hospital stays. And so there's highly trained staff, which involves physicians who are trained towards recognizing symptoms of anxiety, distress, agitation, delirium, and also nursing staff that are trained in recognizing those symptoms and being more proactive about treating these patients. There's also a lot of help from volunteers, which is a very strong part of that team that's managing these patients when they're very sick. And when patients are admitted to the hospital, family is involved because a lot of these patients have anxiety and may have some cognitive issues to begin with. So family involvement is encouraged. So I just highlighted those three aspects: ACE units, volunteers, and family involvement. So because as you'll see, all of these systems and infrastructure that was well established during pre-COVID times was really disrupted when patients when COVID happened. So you can see here that there's a patient, a volunteer is engaging with that patient. This is a common cart that is used, which has all these activities and other things that will keep the patient really involved during the day so that they're awake, they're engaged, and it will really help them sleep at night because that's one of the things that happens in the hospital is that the day-night cycle is really disrupted. Patients tend to just get, sleep during the day. They're up and agitated and restless at night. So during COVID time, elderly patients are definitely at a very high risk for developing acute complications related to COVID. Most of the deaths were in the elderly. Elderly patients have a lot of cardiovascular and metabolic comorbidities. And even without COVID, delirium is a very common presenting symptom that's seen in hospitalized patients. And just having delirium itself has a very high mortality. And a lot of these patients who are frail, debilitated, were getting home visits and home care services, which were significantly disrupted during pandemic. And ageism was a very strong factor in resource allocation. A lot of centers which were really overwhelmed with mass admissions were really had to figure out, which patients would take top priority. And generally the elderly patients were already very frail. There was a bias against which ones would be admitted to the ICU. And social isolation also has played a very strong factor in impacting psychological, cognitive, behavioral, and physical status of frail patients. So just having this background in mind, that really has had an impact on how patients were managed in the hospital during COVID. There were a lot of recommendations about medical management in caring for our patients with multiple morbidities. But unfortunately, there was not a lot of recommendations for how do you manage patients with geriatric syndromes like falls, delirium. Patients were already very frail. There wasn't a lot of input about that. In addition, surgical wards were repurposed to accommodate COVID patients, where a lot of these frail patients would normally have gone to an ACE unit, where they have these trained staff who are monitoring them cognitively, assessing their levels of alertness, engaging with them. Staff was working overtime. There were restrictions on volunteers and family visits. Um, in addition, a lot of these frail elderly patients have poor vision, their hearing is limited. So using technology for virtual visits in these patients was not really very realistic. And what we've seen is that geriatricians were very rarely involved at policy level for making any of these decisions regarding how best to assess for any cognitive change in patients who are admitted to the hospital with COVID. So where you saw that picture with the volunteer is nicely engaging with the patient and keeping them engaged in their day-to-day activities. This was a common scenario of how physicians and patients were interacting when patients were critically ill and admitted with COVID. So when we look at the neuropathogenesis of COVID, there are several different factors that predispose patients to develop cognitive changes following COVID infection. So one is that when the body is overwhelmed with sepsis and systemic dysfunction, as well as hypoxia, that is a big predisposer to neurologic injury. The brain is extremely sensitive to oxygen, and when patients are severely hypoxic, that has an impact on the brain functioning. The renin-angiotensin system dysfunction, I think we all have heard about the ACE2 pathways and all of that, and we'll go through that a little bit. That dysfunction is also responsible for some of the neuropathogenesis. Most of these, there's been a lot of work on looking at coronaviruses, and the coronaviruses have been shown to be, pathogenic to the nervous system with direct viral invasion, as well as the immune response to the virus itself has been more of a double-edged sword, because when patients have COVID and the body is trying to develop an immune response, it causes a hyperactivation of the host immune system, and the pro-inflammatory cytokines, which can induce the cytokine storm, can damage the blood-brain barrier, and that allows the virus to infect the brain. Para-infectious and post-infectious triggers have been also involved in some of the patients who developed Guillain-Barré syndrome after COVID. And they've also noted that there was a presence of autoantibodies in a lot of COVID patients, like the antiphospholipid antibodies. And these patients showed a much higher thrombotic complication. Autoantibodies have been shown to cause like autoimmune encephalitis and other conditions where patients develop NMDA receptor antibodies. So certainly, though all of these mechanisms predispose patients with COVID to developing neurological complications. This is a nice diagram which kind of highlights the different immunological and non-immunological complications of COVID, and we'll go through these in detail. So hypoxemia from multi-organ failure can induce encephalopathy, and multiple studies have shown that neuropathology of these COVID patients showed acute ischemic events, and as well as hemorrhagic and bland infarcts were noted. And neuroimaging also showed that there was hypoxic-induced damage following COVID infection. Now, this kind of pans out to like, why is hypoxia so important in developing these cognitive and neurological decline? The brain needs a lot of oxygen. Muscles can store excess carbohydrates as an energy source, but the brain really has no reserve of energy. So an uninterrupted blood flow provides glucose and oxygen, and the hemostatic brain function is lost very quickly when oxygen is cut off. So if you become very hypoxic, the brain quickly develops neurological damage. And what we know is, especially after a stroke, 1.9 million neurons and 14 billion synapses are lost per minute. So you can just imagine, in patients with COVID who are severely hypoxic, how many of these neurons and synapses would be lost with prolonged hypoxia. And this is just to give you a perspective of how much oxygen the brain consumes. So if you see that the brain, the percentage of total body oxygen consumption by the brain is 25%, as opposed to like the skin or other organs. So definitely the hypoxia is a huge contributor to cognitive damage. This ACE2 pathway is something which has been talked about a lot. There's a lot of articles about this, but this seems to be a very important pathway in causing neurological damage. So the ACE2 receptor acts as a doorway to COVID-19, and the ACE2 receptors are expressed in highly rich areas which have very rich capillary blood flow, like in the lungs, kidneys, and also in the brain. And so damage to this pathway will cause significant cell death. And this is a diagram that, if you understand this, I think it's very easy to understand the main complications related to COVID. So the renin-angiotensin system and the MAS system are counterbalancing mechanisms that the body has. And the balance between these two is required for homeostasis. And as you can see that they work exactly opposite of each other. So the ACE pathways causes activation of the ACE pathway causes vasoconstriction, hypertrophy, fibrosis, proliferation, pro-inflammation, and oxidative stress. And the protective pathway on the other side causes vasodilation, vascular protection, anti-fibrosis, anti-proliferation, anti-inflammation, and nitric oxide. So when patients are infected with COVID, this pathway is disrupted. And so these two balancing pathways, there is no protective pathway that helps balance the two competing mechanisms. And so you can see how if the ACE2 pathway is disrupted, it will cause cell death, fibrosis, endothelial injury, vasoconstriction, and coagulopathy. So this is the main theory that infection with COVID disrupts this ACE2 pathway and thereby leading to cell death and fibrosis. And those areas where ACE2 receptors are in abundance, like in the lungs, the kidneys, the brain, are the ones that show most of the damage following COVID. So, I think if we understand this mechanism, it's easy to understand the pathology of COVID. So this is just another schema of how disruption of this particular protective pathway then leads to these damage, and so that's why lung fibrosis, endothelial injury, coagulopathy, all of those develop as a complication of COVID. The other, other mechanism that's in play with patients with COVID is that the microglial cells, which are the main defense cells in the brain, are strongly activated by COVID infection. And this then triggers the migration of the natural killer T cells, and that causes neuroinflammation in the brainstem. And a lot of these immune changes are present in the small blood vessels of the brain where the ACE2 receptors are present. And so that can explain this, thrombotic injury leading to thrombotic events like strokes in these patients. And then we talked a little bit about the direct neuroinvasion of the virus itself. That can also cause encephalitis and stroke and seizures. So these are the main, obviously, there are probably factors in each patient that will predispose them to one over the other. But for the most part, the ACE2 receptor activation, the immune receptor, immune system hyper activation, as well as the direct invasion of the virus and toxic effects on the brain by the virus itself can cause all the complications that we see neurologically in patients who have COVID. And these are some studies that have shown, some of the common symptoms, neurological symptoms: anosmia, weakness, fatigue, depression, headache is a common one, anxiety, and altered mental status. The more significant complications like ischemic strokes and hemorrhagic strokes were not as common, luckily, but those are just some things that we have to bear in mind, particularly in patients who already have underlying cardiovascular risk factors, patients who already have had prior strokes. Those patients are going to be at a much higher risk for developing these complications with strokes and other thromboembolic events. And these are just some other studies that you can see how, neuropsychiatric disorders and headaches, delirium, nausea were some of the common symptoms that patients with COVID reported. The smell and taste, I think, was the most common one. It's also an early symptom of COVID. It can occur in the absence of any nasal congestion or discharge. And the theory is that the SARS-CoV virus invades the brain through the olfactory epithelium and then the neural mucosal interface. And in general, 5 to 8 days is sort of that time period where these symptoms last. But loss of smell is actually a common symptom with other viral illnesses. But obviously with COVID, that was one of the big things that was noted very early on in the disease onset. The cerebrovascular events were relatively infrequent, but ischemic stroke was one of the common ones. Thrombosis as well was noted, but not as common. And these symptoms usually happen 1 to 3 weeks after the onset of COVID symptoms. And patients who have underlying vascular risk factors, patients who have developed myocarditis after COVID are at a very high risk for cardioembolic symptoms. And the management is really very similar to what we would you do for stroke patients. The same thing with thrombolytics, thrombectomies, and really addressing those cardiovascular risk factors, blood pressure, and other support that they need. And in these patients who have underlying cardiovascular risk factors, making sure that all preventive measures are taken so that their risk for developing severe COVID is reduced. Neuromuscular disease is also seen not as frequently, but Guillain-Barré syndrome, myositis, as well as there was a lot of mention about peripheral nerve injuries after proning position, axonal damage, brachial plexus injuries were noted related to the positioning of COVID patients during the treatment process. Some of the others, these were not as common, and they are mostly case reports. Meningoencephalitis, ADEM. In children in particular, the multisystem inflammatory syndrome was noted. Initially, reports started coming out of UK, and then, really all across the globe, there were case reports of this. In New York, they had over 100 kids who were noted to have this generalized myoclonus, and posterior reversible encephalopathy syndromes were some of the others. This is just a little bit on kids. I know that we focused a lot on adults, but in kids, this is a fairly significant syndrome, and it presents with Kawasaki-like syndrome in kids, and they also have a lot of inflammatory markers that are elevated. And so definitely in children who are less than 21 years of age, if they present, checking for these inflammatory markers may help make some of the diagnosis. So encephalopathy is one of the most significant complication related to neurological complication. And in patients who have a history of neurological disorders, cancers, strokes, diabetics, heart failure patients, these patients are at a very high risk for developing encephalopathy. And usually the patients may be either very hypoactive, they're just very lethargic and difficult to arouse, or they may be agitated and need to be sedated. And patients who are in the ICU or who are on pressors, these were some of the common issues that they faced. There were, the role of glucocorticoids in patients with encephalopathy was debatable. And I think that, when patients were very hypoxic, definitely the glucocorticoids did play a role in that. But it wasn't very clear if the glucocorticoids themselves could predispose to some of the delirium in these patients and further exacerbate their condition, and so thereby, didn't really prove to be overall very helpful. So what I want to focus a little bit on is the management and recognition of delirium in these patients during their acute illness. And just a fun fact is that the term delirium is actually from a Latin term, which means going off the groove or a track. So day is off or away, and lira is a groove. In ancient Rome, when a farmer was plowing his field and went off the track, he was said to have committed a delira. So when patients with agitation, restlessness, confusion, sedation during a COVID infection develop the delirium, their length of stays are much longer. They have a higher 30-day mortality, and also when they recover, they are in a significantly worse functional state, and they need a lot of additional caregiving and support as their condition improves or stabilizes. They don't really get back to their normal function. And so really recognizing the delirium itself is important, because a lot of times if there's a change in the condition, is it related to worsening of the illness, or is it, a complication of the medications that the patients are using? It's usually a multifactorial thing. And delirium, the hallmark is usually a waxing and waning level of consciousness. So the patient may be awake and talking, and everybody feels like, oh, wow, the patient has turned the corner, they're improving. And 2 hours later, they're pulling out their lines, they're trying to get out of bed, they're very irritable and need to be sedated. So this waxing and waning level of consciousness is the hallmark of delirium. Patients are usually, they have a lot of delusions, sometimes hallucinations as well. And in patients who are in the ICU, this is usually a sign of poor prognosis. Um, there is another term that we use in end of life called terminal delirium, for patients who are close to um, end of life. They may experience agitated state, where they need to be sedated and for comfort care. For patients who are in the ICU, there are several different ways of assessing them. But the most common is the confusion assessment method. And this assesses a change in their mental status, inattention, as well as disorganized thinking, and their level of alertness. And this, I put a link of how to access this tool. But generally, the ICU nurses can be trained on recognizing this, and also using a delirium screening checklist, which will be helpful in assessing these patients on an ongoing basis and monitoring for any improvement. The best way of managing confusion and agitation in the hospital is the non-pharmacological treatments. And again, this was a huge issue with the pandemic, where usually we want familiar family members to visit them and continue to reorient them. Volunteers try to keep them awake during the day, engage with them in various activities, so that they're constantly reminded about where they are, what's going on. But all of those were things that were significantly affected during this time. If the patient is extremely agitated or restless, using benzodiazepines like lorazepam, or antipsychotics like haloperidol are generally indicated. And haloperidol is fairly easily available in the hospital setting, and it can be used IM, IV, or orally. And these are the different doses. Now, the problem with the haloperidol is that it has very high anticholinergic side effects. And so it's not generally well tolerated. But because if it's a short-term use for a few days, it may be worthwhile trying. There are second-generation antipsychotics which have less anticholinergic side effects, but they do have a FDA black box warning about them. They cause a lot of QT prolongation, and if the patient are on medications, antibiotics in particular, then that can be an issue about combining these antipsychotics, anti-nausea medications as well. So those are just some olanzapine, risperidol, quetiapine. These are some of the antipsychotics that are used in the hospitalized patients, and even at home. If the patient is getting restless, anxious, these are some of the agents that are available to be used. Now, everybody has heard about the long haulers after COVID. These are patients who've had COVID and their symptoms are persistent for more than 12 weeks after the initial infection. And these patients usually may have neurological, pulmonary, cardiac, or GI dysfunction, which is persistent after COVID. And generally, it's thought to be autoimmune mechanism that's involved in this, implicated in the lingering effects of these patients. So the most frequent symptoms that these patients in a survey referred to was brain fog, or lack of being able to focus, difficulty in word finding, confusion, headache, dysgeusias, and anosmias, myalgias were some of the other ones. Short-term memory and attention was the common thing that patients would always complain about. They resembled those patients who had traumatic brain injuries and chronic fatigue patients. So when these patients are seen as follow-ups, usually we would want them to be evaluated in a outpatient COVID-19 clinic, or if their symptoms are more respiratory based, where they're short of breath, having a lot of fatigue, maybe you want to have a pulmonologist follow up with them. If they're having more symptoms of confusion, maybe neurology or geriatrics would follow them. If there is no specialized COVID clinic that is established at your center. And this is a good time to review any advanced care planning. These patients have really survived a fairly significant illness, and definitely, risk for ongoing complications are present. So it's always a good time to review with them that you're recovering from this illness. You still have a long ways to go, but if you develop more complications along the way, you're 85 years old now, or 80 years old. How do you want how do you want your management to look like? If this happens to you again, do you want to go back to the ICU and go through this whole thing all over again? Or would you at that point feel that, I've really come out of it. I'm happy that I'm here with my family. I'm still able to be somewhat independent. But if this happens again, I don't think I would be able to really get back to a good function. And, maybe I don't want to go through the ICU again or being intubated again. I think that, while we are so focused on managing and trying to get them through their acute illness, sometimes looking at what quality of life will the patient have at the end of it is also a good perspective to present to the patient and their family, to make sure that we're doing things to improve their symptoms, but also we are trying to have an impact on their quality of life. And if it looks like they already have a lot of comorbidities and we are not going to be able to impact their quality of life as much as the patient's goals are, then it's a good time to review what the expectations are, and how they would want to be treated if they have ongoing complications down the road. you know, labs that you would be following up would be mostly based on symptoms. Usually inflammatory markers are not monitored, you know, in these long haulers. The WHO guidelines are that we remove the isolation based on active symptoms. So if the patient had initial symptoms, they are not immunocompromised, and now they're afebrile, they are not having any elevated white count, you don't have to isolate them. You know, 10 days is kind of 10 days post active symptoms is the recommendation for immunocompetent patients, and 20 days post active symptoms for those patients who um, are immunocompromised, like patients with cancer or elderly patients. So this is a screening checklist for developed by the Society of Critical Medicine for those patients who have who are being monitored, you know, after a critical illness, and you know, really monitoring 5 different domains will help us understand and keep a close eye on how they're doing down the road. So looking at making an assessment of their cognition, looking at their short-term memory, attention. The MOCA is a test that we use here quite often. MMSE was being used before, the mini mental status exam, but there's been a lot of copyright issues related to that. So there's a shift towards moving away from that and using the MOCA at this point. And those are the scores. It's a 30-point scale. And if the patient scores less than 10, that means that they have severe cognitive impairment. The anxiety and depression scores are, again, something that are followed. Patients may have a PTSD after recovery from COVID, or functional decline, and doing a 6-minute walk test includes an assessment of their mobility, their ability to self-care, as well as also looks at their scores on pain and anxiety and depression. So these are some domains that can be monitored for patients who are dealing with ongoing symptoms for more than 12 weeks after they've recovered from COVID. Now, there are a lot of reports now about vaccination may ease some of the symptoms of long COVID syndrome. In a very large survey that I was reviewing, 50% of the respondents reported an overall improvement in their symptoms following vaccination, while 19% reported a deterioration. But one theory is that the vaccines may stop the harmful immune response in long haulers, and it could reset the immune system. And so whatever virus or other things that are lingering might be able to, you know, be responded by the immunization itself. And I just want to read a quote from one of our patients who said that it was like a revelation after she got the COVID vaccine. The brain fog cleared immediately. Muscle aches were gone, joint pains were less intense, and I suddenly had more energy. It felt like the old me. So vaccination is definitely recommended for these patients after they recover. And if you want to know more, there is a neuro data bank that has been established by the NIH here, and they're collecting all the data and tracking these patients who have recovered from COVID and are having neurological symptoms. So it is still an evolving subject, and I'm sure that we'll get more information about this over the next year or so as we collect more information. But this is pretty much a summary of my presentation, that while the neuro symptoms are common, we still have to exclude other findings, and delirium is usually a marker of acute brain dysfunction, similar to shock in a cardiovascular patient. So it is to be treated with the same respect that you would treat if the blood pressure is down, and making sure that we monitor these patients. If a patient is on immunosuppressive therapy, we would continue the immunosuppressive therapy. It should not be discontinued. And one of the things which here in the US particularly, we've noticed that the pandemic has highlighted the significant disparities in race, ethnicity, education, and low income, and the same risk factors that these minority population face in terms of cardiovascular disease, obesity, diabetes are also predisposing them and making them more susceptible to COVID. So that's these are some of the references that I used, and any questions at this point, I'll be open to that.
Thank you, Dr. Kavita, for wonderful presentation and a lot of insight about today's scenario on COVID. Before we open the question answers round, I would like to acknowledge the medical associations and the representatives over here. So we start with Dr. Chong from Singapore Medical Association, also the chair for CMAAO. We have Ravi Naidu from Malaysia Medical Association and the past president of CMAAO. We have Mr. Nazmi from first vice president of CMAAO and from Pakistan Medical Association. We have Dr. Elvin from Hong Kong Medical Association and treasurer from CMAAO. We have Martinda Pillai from Medical World, from member of World Medical Association and Sri Lanka. We have Dr. Salma Pundi from Pakistan Medical Association, Dr. Angelica from South Africa Medical Association, Dr. Jamaluddin Chaudhary from Bangladesh Medical Association, Dr. Sajjad from Pakistan Medical Association. We have Dr. Mary from Japan Medical Association, Dr. Shashank Joshi, endocrinologist from India. We have Dr. Bukhari from Pakistan, Dr. Brahm Vasudev from US, Dr. Monica Vasudev from US. And then we have Dr. Sanchita from IGCP Group India. And now I would like to invite Dr. Chong to chair the session with me.
Thank you, Sarab. And thank you, Dr. Sharma, for that brilliant presentation. I mean, it's not often that we think very much about these neuropsychiatric complications of COVID and so on. So I think it's quite fascinating. So I would say that to my understanding so far, it's a direct effect by the virus itself, or it can be delirium secondary to many of the complications and that occur because of COVID. And then finally, of course, there's the neuropsychiatric elements themselves, post-traumatic stress and so on. Am I right, Dr. Sharma?
Yeah, I mean, the medications that, the metabolic changes that happen to the body when the patient is septic, when the patient is hypoxic, all of those definitely can cause delirium. But not everybody develops delirium. So the ones who develop it are at a very high risk for mortality. And they have to be aggressively recognized. Patients who are elderly, patients who have cardiovascular risk factors, patients who've had prior strokes, those are the ones that will develop the delirium, and then those are again at a high risk for mortality. So the medications also do contribute if they're on ventilators and we are using sedation, pain medications. All of those will also cause delirium.
Yep. So yeah, we do see quite a bit of this in ICU patients. I like to call it ICU psychosis. Okay, I'll open the questions to the floor. Anyone has any questions for Dr. Sharma?
Yes, I am Professor Bukhari from Pakistan. Thank you very much. It was really a nice, really a nice lecture, and I would like to ask one question, and I would like to give one more comments. We divide the sign and symptom of the COVID into post-COVID disease and post-long haulers. And again, the neurological disorder and the brain fog, two are different things. One neurological disturbance is due to damage, systemic damage of the brain or nerve endings or something else. While fog is just a confusion, just like a confusion, and you are not fully engaged. And Dr. Sharma has given a beautiful pauses. But one thing I want to add, that there may be a reduction in the G lymphatic system of the brain. When the blood vessel passes from the arachnoid matter, there is a periarterial space. From the periarterial space, this is called the lymphatic. And the CSF penetrates from here, and it washes all the cytokines, everything from the brain, and go by to the sinus system. So in the corona, in the COVID, what happens? This G system is compromised. When it is compromised, the more things that will stay there, there will be no washing out of the cytokines, there will be no washing of the debris, and that will cause the fog. That is called the brain fog. That is a transient phase. Another important cause Dr. Sharma has given, that is, this is the autoimmune antibodies. And sometimes, so I think this was my comments. And one other, my question from Dr. Sharma was that what is the difference between the gender? Either these all symptoms, neurological symptoms are seen in the males or more in the female, and what is the cause?
They are seen more in males. I think the cardiovascular risk factors, those have, it's more common in those patients. Although the studies have shown that, the severity of the systemic illness does not predict who gets, the brain fog. Some patients who didn't even get hospitalized and had very mild illness, they just had, just for a few days they were sick and just didn't even need to go to the hospital, also developed the brain fog. It is a transient state, but for a lot of patients, they do say that, it's been months and they still feel that their attention is poor. So it's basically, the feeling is that there is probably some residual virus that is causing an immune response. And when you vaccinate these patients, there is some benefit to that. It resets your immunological response and helps combat some of those side effects that are still lingering from, either the virus itself or the immunological response from the virus. So, but the males were more common.
Dr. Sharma, what I want to add is, you are right, that if the virus is persistent there, that will cause the damage. But if fog is not a damage, it is just like the reduction in the lymphatic system. When the reduction of the lymphatic system is moved off, it is not due to the virus present. It is not due to the virus present. It is due to, you can say, yes, sir. Yes, sir. Thank you very much. Another thing, in our study in Pakistan, we have seen that the cardiovascular damage is more seen in males, while the vascular anxiety, these fogs, these are more seen in the females. Thank you very much, sir. Thank you very much, doctor.
Okay, that's good to know. I know that, geographic distribution is always
Thank you very much.
Okay. All right. That's
Dr. Kiran, I would like to present a case.
Sorry.
I'm Dr. Kiran from Delhi. I would like to present a case. Like I got a call post-COVID, about 45 years old male with schizophrenia, and he was already on olanzapine 20 milligram. there was a lot of delirium, means delusion, and he was going away all the time and agitated. I referred him to hospital, but admission was very difficult. So I just increased the dose of olanzapine by 2.5 milligram. I gave it for about 10 to 15 days, and that patient became all right. I just want to know whether I did all right or I did it on my own, without admitting, without anything. I just increased the dose of olanzapine and patient became all right. He's still all right.
I think that, obviously you're trying to treat the acute. In the acute phase, you do want to, improve the symptoms. So the antipsychotics will help with that, and, help manage some of those agitation. And it's possible that this was related to, it could be a transient phase from the COVID itself. And over a period of time, it may improve. Increasing the olanzapine was the right thing to do. You can, observe him for a few weeks and see if you want to lower the olanzapine later on, because olanzapine itself has a lot of metabolic side effects and other things. So continue it for now, but I would say that as things stabilize, and just observe him for several weeks and then try to wean him down after that.
Alvin, you have something to ask? You have a question to ask?
Thank you. Yeah, nice to meet you all here again. And thank you very much, Dr. Sharma, for the excellent, enlightening lecture. So I am a child neurologist. However, I don't have much experience of COVID-19 in pediatrics in Hong Kong. Well, there are very few cases, in fact. And in fact, even in the study by the UK, Great Ormond Street, they also found only few pediatric patients with MISC. And in fact, majority of their patients in their studies with MISC are not whites, are not Asians, and not Chinese, but many of them have been African or South Asians. So I don't know whether in your studies that you had quoted, especially in the MISC group, are they more of the whites or blacks or?
They are mostly African Americans.
Yes, I see. Yeah, and so especially when you mentioned that vaccination had caused 57% improvement in the encephalopathy and delirium encephalopathy, and about 27% deteriorated. Yeah, so any explanation about it, and what kind of vaccines were used? They were mRNA vaccines?
The mRNA vaccines, yeah. Moderna was, the most common one that was studied.
So in fact, my understanding of many of the neurological syndromes after the viral diseases had been post-infectious ones, and in fact, it's some sort of some cytokine and hyperimmune reaction, and then targeted the neurological system, like a Guillain-Barré syndrome, or I don't know whether this MISC involving the brain, or in adults, and not MISC for the encephalopathy and other things. They had evidence showing that they are some issues of the post-infectious elements, or they are direct infection by the virus.
I think it was post-infectious.
Yes.
For the MISC.
So the vaccination, the factor of vaccination in changing the course. So by the way, with the infection, they will give one dose of these mRNA vaccine, not two doses, I guess.
No, after the first dose itself, a lot of patients felt relief, but after the second dose, they had much more. Like a lot of the patients, within a few days of getting the first dose itself, they started improving. And
Yes,
after the
Dr.
second
Sharma, you are
dose, they
right.
had much.
We have seen even after, sir, we have seen the improvement even after the first dose. These are actually when the patient is getting vaccine, he is getting more reassurance. When the reassurance, basically after first dose, the symptoms may start improving.
Thank you. Dr. Pillai here from India.
Thank you very much.
Yes, Dr.
Yeah,
Pillai.
can I, one or two questions? It has been a very excellent presentation. All areas have been well covered. One thing is proximal myopathy. We do come across in some of the post-COVID patients. Have you seen any patient, Dr. Sharma, in the States? Second is the stroke, ischemic stroke. Is it a small vessel ischemia, which is more common, or middle cerebral artery, posterior cerebral artery thrombosis, which lead to ischemic changes? And the third question is, monoclonal antibodies are being used now. Does it in any way help in management of neurological complications? Thank you.
Thank you, Dr. Pillai.
So yeah, those are good questions. The small vessel disease is what, the ischemic strokes are mostly in the small vessel disease. We do see, because the theory is that the ACE2 receptors are present in capillaries, the small vessels, and so that's the site where, of attachment of these, of the virus. And so the small vessels are the ones that are damaged by COVID infection. And the strokes are, ischemic strokes are, in the like lacunar infarcts, microinfarcts. The myopathy is a common, symptom, and any viral infection actually, you can have a lot of myalgias and myopathies. So that is a common, condition that we are seeing here. And what was the third one?
Monoclonal antibody.
Yeah, the monoclonal antibodies, like they have, when patients have developed Guillain-Barré syndrome and they've used them in those patients, they've shown, benefit for those kind of situations.
Thank you, Dr. Sharma.
Thank you.
I have a question, if I may.
Is that Dr. Salma?
I'm Dr. Salma Kundi from Pakistan.
Yes.
Good morning to everyone. My question is that I've come across a few people who have gone through COVID, and a few weeks after that, they've developed tinnitus, and most of them have also developed floaters in the eye. Do you have any study on that?
Yeah, there was, I think in my, I did mention that there were, I've quoted this, one of the articles which I reviewed. I can, I can share the presentation, and the links for some of those articles are there, where the tinnitus is one of the symptoms that you can see. They can also have headaches is another one. Floaters in the eye, I did not come across anything like that. But if they've had any kind of small vessel infarct or other small vessel damage, it's possible that it could be a symptom of that.
Dr. Sharma, I've gone through COVID, and after 4 weeks of my initial symptom, I've developed tinnitus, and it's really, really irritating me. And I've gone to 4 ENT specialists in Pakistan, and none of them has a very good answer or something that I can come out of it. If you ever find the treatment for it, please do contact me, And I'm coming up
Okay.
with a paper now because in my area in Pakistan, Abbottabad, personally, I know 5 people who have the same symptoms. And then we'll go from there.
Okay. Okay. Yeah.
Dr. Salma, it's very interesting, this symptom of tinnitus. I had a patient who had tinnitus recently, again, due to COVID, and he found this very interesting little device called, made by Flare Audio. It's actually used by sound engineers to improve the quality of the sound when you listen to it. So when you're listening to good music, you put it in your ear. It's just a little piece of plastic. And apparently it helps a lot with the tinnitus. They found it as a sort of side effect. So I'll send the link to you.
Okay, thank you so much. Thank you, Chang.
Yeah, and interestingly, just some things were mentioned, for example, the myalgia and all that. I think that's due to immune complexes being deposited all over the muscles and the inflammatory forces coming to attack the immune complexes. And also very interesting, Dr. Bukhari mentioned something about lymphatics. I remember reading something about lymphatics in the brain only being discovered recently, last few
Yes,
years.
sir. Yes, this is the new study.
Yeah.
Yes, I want to explain again. Because usually the cerebrospinal fluid circles in the meninges, and from the meninges, it goes back to the venous system. But when the blood vessels passes from the arachnoid space, there is a space around them that is called the periarterial space. In the periarterial space, this cerebrospinal fluids comes, and from the water channels, it comes out in the brain tissue and washes all the debris, all the cytokines, all every inflammatory products, all the viruses, and again goes back to the vascular system. What happens in the COVID? This G lymphatic, or in other words, the lymphatic system is disturbed. You have seen that is loss of, and this is the more lymphatic system in the olfactory nerve, in the cerebriform, and the virus disturbs this olfactory system. And when this olfactory nerve is inflamed, all the lymphatics are blocked. When the lymphatics are blocked, there is a fog. How can we reduce the fog? There are 3 main systems. You just wash it like this. This is called the massage on the cervical area, carotid area. Another is you go this one. You move your spinal cord. This one. And third is the good sleep. When you are sleeping, your neurotransmitters are reduced, and your lymphatic system starts working. When it starts working, you become okay. And the third treatment is go to the neuro specialist, and also the use of the melatonin. Thank you so much, sir.
Thank you, Dr. Bukhari, for that very interesting.
That's very nice.
Thank you so much.
Yeah. Okay. Anybody else has any questions for Dr. Sharma? If not, then we do a quick roundup of the various countries, if we can, if we have some time. But we don't have that much time.
We would request you to only keep yourself limited to 2 minutes, because we will have another session. So every country can give an update for a couple of minutes, and we'll be ending the show in next 15 minutes.
Dr. Jamal, do you want to start?
Yeah. Oh yeah. Thank you so much, Dr. Chung. Actually, in Bangladesh, we are going for complete shutdown in the next 2 days. Actually, for 7 days it will start. May explain, because it's increasing, especially in the border areas. But the capital is just surrounded by the districts. They are already locked down, but the capital itself is going for shutdown for 7 days at least. So the cases are increasing, and the number of deaths are also increasing. So the problem is that we are short of vaccination, much shorter. I don't know how CMAAO can play a role in just having this vaccination equally or near equal is available to all the countries. Otherwise, the world is going to face a challenge, actually. Thank you.
Thank you, Dr. Jamal. Sorry to hear this unfortunate situation. Dr. Pillai, do you have some updates for us from India?
Thank you. India, of course, we are overcoming the second wave. The cases have come down to 40,000, that range, and definitely we are overcoming it. And vaccination is going on very well. Almost 8 million people are vaccinated per day. At this rate, by the end of December, we will be able to vaccinate our 990 million population got to be vaccinated. And the side effects of vaccination, fortunately, is very, very low, 0.003%. So that is something very encouraging. Then, of course, the variant, Delta variant, now we have Delta plus, at least 76 cases have been identified, and the transmissibility is high. Lung involvement is very high, and even mortality seems to be high. So we are taking every step to control it. But Delta plus variant is not isolated even in India. 12 countries already have this variant, and in every country, steps are being taken to control. So we are cautious, but we are optimistic, and things are under control. Thank you.
Dr. Pillai, is it immune escaping?
Some of the studies show that the total number is not that huge, but it is escaping. The WHO yesterday's publication, they mentioned that.
Thank you, Dr. Pillai. Dr. Salma, do you have anything to update us from Pakistan?
No, thank you. Sorry, it happened by mistake when I raised the hand. Thank you so much. It was such an informative talk. I'm really, really grateful, because I was wondering about blurred vision, tinnitus, and floaters. And now let's all go into that and find treatments for it. All the best for everyone. And thank you, Dr. Sharma and Dr. Chang and Dr. Bukhari, for a very enlightening talk. Thank you.
Thank you. Angelique, do you have something to tell us from South Africa?
Morning, just struggling to unmute. Yeah, we are going through our third wave, which is terrible. We are seeing numbers that we have not seen yet in South Africa. And the province that I'm working is the epicenter of all of this. And I can promise you, I think I'm an expert on primary healthcare COVID-19 patients, because we are seeing them on a daily basis. But it's interesting. You can treat your patients out of hospital. You need to understand what your SATS monitor and your pulse rate is actually telling you. And by doing that regularly on each and every patient, you start to get the feeling for who is going to be able, maybe crash or going to give you trouble, as I've said. And oxygen, very, very important. Home oxygen, one of the gold standards. We, unfortunately, our hospitals already overcrowded, so you don't have a choice than to start treating your own patients at home. And really, tinnitus is part of the problem. I have seen it, but there's not a lot that you can do for tinnitus. Most of these patients, what we have seen, if your SATs are low or around about 88 or under 90, let's go like that route, they tend to cough. They tend to cough a lot. So that is sort of guiding you that it's a SATs problem. Tiredness is a very, very irregular pulse rate. So and the nice thing is, if you can educate your patients, especially on the oximeter, they start to understand why are they coughing if they are physically active. Physically active means walking 5 or 6 steps, and why they are tired if they look at their pulse rate. So those two little indicators is actually so important. That and oxygen and bed rest. I call it the lazy disease. You need to be in bed. You need to be lazy. Thank you so much for this morning's presentation. It's a very informative. And yes, we are going to go through this wave because our government didn't listen when we told them that we need stricter restrictions. and now it's too late. Once the genie is out of the bottle, you'll have to go through it. Thanks.
Thank you, Angelique. Prof. Ashraf, do you have anything to say to us? Prof. Ashraf, are you there?
Hello, otherwise, Alvin from Hong Kong.
Okay, Alvin, please.
Thank you very much, Sean.
Okay, yes.
If I just say a few words, if everybody can listen to me. Yeah, thank you very much. Pakistan, Alhamdulillah, we are fine. Now the ratio positivity is about in between 2.5 and 1.5. The situation is much better in Pakistan, but we are just suffering from the vaccination. Vaccination is a big issue in Pakistan. We are having very low vaccination system, and procurement by the government from the international agencies or the countries. It is also a difficulty in Pakistan that we are not good in vaccination. We have hardly done about 4% of the population till now, till today, and we are waiting as the NCOC has said that we may have the fourth layer of this COVID maybe in July or August. We are apprehended about it, but at the moment, Pakistan is quite safe. Thank you.
Thank you,
Dr. Nizami. Dr.
Yes.
Nizami, how you have escaped from the invasion of the Delta?
We are lucky. We had about 5 or 6 cases, but lucky one Pakistan that we have control. We have control on our borders. As the participation of the Pakistan Medical Association, we lauded about all that and pressurized the government. Borders were almost open, but when after having this issue to our neighboring country, the border control was better in Pakistan, and that is one of the reason I believe that we have controlled it.
Thank you.
Thank you.
Dr. Nizami, I want to add one thing. In Pakistan, we are still following the strict SOP, mask and everything, in not only in the bazaar, in the markets. We have closed our shadi halls and other halls in the classes. If any students is not wearing the mask, then so no doubt we are lucky, but we are also we are applying the strict SOP. And one more thing, our today's vaccination is around about 1.1 million. So we are, 10 million. We are crossing this. And in the July, we are getting more than 50 lakh vaccination from the Pfizer's and from the other countries. So no doubt in last few days, it was slow. But the government of Pakistan is now daily using vaccine around about more than 10,000 daily. So in the July, the speed will be inshallah high. No doubt we are lucky, but we are very strict in using the SOPs in hospitals. Still in Sunday and Saturday we have lockdown. So these two. Another thing Dr. Nizami has told that our borders or the border. Another thing, sir, there is strict no Delta or Delta plus in Pakistan. That is around about 70% more transmissibility. So that is why still in Pakistan it is B117, that is the urea. And we are vaccinated, and the vaccination reinfection again good, around about 0.066% of the reach rate. So these
Dr.
are the
Bukhari,
we
would like to be quick on this discussion. Now we are ending our point. Yeah.
Alvin, can we talk? Let Alvin say something.
Yes.
Alvin, is he still around?
Dr.
Alvin, are you still around? I think he's gone off. Ravi? Is Dr. Ravi still around?
Okay, can we have
Mari?
Okay.
Ravi, are you still around? Marie, maybe you can tell us what's happening.
Yeah, thank you very much for the very informative lecture, Dr. Sham. And in Japan, we experienced kind of the end of the 4th wave. And of course, we are preparing the 5th wave right now. Fortunately, the people 65 and older had a vaccination about 50%. So it's good news. But of course, all of you know that we are going to have Olympics, because the government saying that we are checking everybody who is coming to the Japan. But of course, some escape cases is happening right now. So we have to prepare for the 5th wave. Thank you very much.
So what is the opinion of the Japan Medical Association regarding the Olympics?
No official announcement is released, unfortunately, because you know that Dr. Yokokura resigned from the president, and the new president is kind of struggling to organize everything.
Okay.
Can we have Dr. Shashank Joshi for Indian?
Yes, please.
So as Dr. Pillai said that we are a little better than before. Number of cases and the second wave is receding, but still we have a large patient population. The wave has picked up in the last week exponentially, and we hope to complete our vaccination in the next 3 to 4 months. Most places, the lockdown restrictions are getting eased out, but still a lot of vigil is being maintained. The only concern last week was the so-called Delta Plus, which is AY1. 40 cases were reported of AY1, which is mainly seen in United Kingdom and Nepal. And the Genomic Consortium of INSACOG and the Institute of Integrated Biology and Genomics from NCR region, Dr. Anurag Agarwal's team, has published some data with the Cambridge team of Dr. Gupta. And they have found that these 40 cases which were seen, one patient from Ujjain Rishinagar has died, who was not vaccinated, and one patient from Maharashtra has died, who was comorbidity with senior citizens. But by and large, most people had mild to moderate disease. The data sample is too small for any conclusion. Probably the R0 is not as high as the delta. So many people feel that this so-called delta plus or AY1 may be actually delta minus. But again, we don't know whether it escapes the cocktail antibody, but data from UK suggests it may, and whether it has immune escape to Covishield. But these are all exploratory measures. Because of the concern of delta plus, some states have been put on red alert again. Maharashtra is one of them. So we are cautious and careful, but at the same time, overall, the second wave is on the receding path, and we are in a little better position than what we were last week. And the vaccination is now on a higher note, and we expect that with every passing week in the July month, we will have almost 22 crore vaccines available. So we may, almost start touching more than 50 lakh vaccinations, which is like 5 million vaccines per day, which is an impressive number. And we will probably be able to complete the vaccination as early as possible. But that is our primary target. We have 3 unlocking principles which we are following. Have a test positivity rate with RT-PCR less than 5% for 2 weeks. Second is try to saturate 70% of the geography with vaccination with 2 doses. And third is to have zero tolerance for non-adherence to COVID-appropriate behavior and protocols. And with that in mind, the unlocking is happening. Thank you.
Thank you very much. That was excellent. Just want to update you on Singapore. So Singapore, we're proceeding with about 80,000 vaccines a day. We've crossed 5 million doses administered to a population of 5 million. So that's about more than 50% of the population is now vaccinated. About 40% of them have 2 doses done, the rest one dose. And we are also experiencing the Delta variant in community spread. For example, we have clusters in our housing blocks. 90% of Singaporeans live in housing blocks, public housing blocks. And we have in the wet markets and in shopping malls. So we are also interestingly doing acute rapid antigen tests, ARTs, so rapid antigen tests. And we are also doing wastewater checking. So we actually check the effluent, the sewage effluent of certain blocks, and to look out for any kind of spread. And as a result, we've actually cordoned off some of the blocks and mass swabbed everybody. So that's one of the interesting things we are doing. Otherwise, we have to, finally, the word is we have to live with it. So endemic, and that means it has a lot of implications for the isolation, testing, tracing, and the quarantine that is ongoing. So we have to relook at everything and figure out how we're going to live with the virus. And that's all for Singapore. Thank you.
Okay, I think we should end the session. We have people coming up for the other session, and the bad boys, we're taking over the session for other people. So we have roundtable conference now scheduled in next 1 minute. and we have already seen people joining in. So this is the end for the 64th session for International Weekly Meeting by CMAAO, non-stop session started by Dr. K.K. Agarwal. And I think we have wonderful speakers over here. We have wonderful attendees over here. I'm glad that people are changing their schedule to join this meeting. So thank you so much for being here. See you next week. We will bring up more topics and more sessions. Do give us your feedback and comments, and do share this platform. Thank you so much for everyone joining.